Okay, let's go to speaking. Right. Speaking in OET exam is quite short, actually. Usually, this is the test format. There's a warm-up session, which is 1 or 2 minutes. It is not assessed. It is not recorded. It's just a chit chat. How are you? What's your name? What's your profession? The reason for that is for you to feel comfortable and then to find out what your occupation is, because speaking and writing are occupation specific. So basically, you do the speaking test for doctors and writing test for doctors. Okay. Then you will be given a role play card, which gives you a scenario. You have 3 minutes to prepare and 5 minutes to play the role. And then you will have 2 consultations, basically 3 minutes, 5 minutes, again 3 minutes, 5 minutes. The person who's sitting there in front of you is called an interlocutor, and this person is not your examiner. Your voice is recorded, and then it is sent to Melbourne, where 2 examiners listen to it and they mark you. Okay, so basically the person who's sitting there in front of you is not your examiner. So whatever you do needs to be on the recording. The criteria for assessment of speaking has changed since September 2018. Okay, and before September 2018, this current was the assessment criteria. The reason I'm telling you is because there are so many role play cards that belong to that period of time. Okay. Excuse me. So, in the old system, in the previous version, what happened was they give you a piece of conversation, and in fact, it wasn't a complete one, like this one. Okay, it's a role play card. Okay, this is August 2014. They don't give you the patient one, they give you the doctor one. Okay. In this task, they give you a scenario, basically the setting, suburban medical clinic. Then this is the background information. Then they give you a task. And you were supposed to, in the previous system, you were supposed to cover all of these. This one, this one, this one, this one, this one. Okay. So it's 1, 2, 3, 4, 5 items that you had to finish. And this is the old system, and it's no longer the case. Yeah. Okay. And this is very important to understand, that if you see any cards that just tells you be sympathetic and reassure the patient, it is an old version, and I will tell you why. Excuse me. Previously, overall task fulfillment was, it means how many of those bullet points you're covering. Right now, it's not that anymore. They've actually changed this overall task fulfillment to a new set of criteria, which are called communication skills. Okay, and we'll look at that in a moment. The language criteria hasn't changed. We will just have a look. So very quickly, this overall task fulfillment has, which used to have 100 marks. Can you see that? There's 1, 2, 3, 4, 5 criteria, 100 mark each. It has changed. Okay. Now look at this. Those who used to be 400 marks, they have reduced their marks. There's now more marks for communication criteria. Okay. So basically, they have doubled the mark for communication criteria, which was the overall task fulfillment, and they have there are now less marks for this part. Okay, I would say nearly 300 marks for this for the linguistic, 200 for communication criteria. Okay. Um, okay. The linguistic criteria is obvious. Basically, intelligibility. Very quickly. What does it mean, intelligibility?
Being understandable to...
Okay, good. Very good. Okay. So how well a candidate's speech can be heard and understood. Pronunciation, you know. Rhythm, do you know rhythm? How fast you speak, how slowly you speak?
Something mediocre, not too fast, not too
good. Yep.
slow.
Yep. Something in between. Stress, word stress. Which part of the word you stress? Intonation.
Stress in the sentence.
In the sentence, yes.
Yep. Okay. Where you increase your voice, where you bring it down, where you stress. Pitch.
The loudness for voice.
Okay. Yeah. Pitch is for some people it's difficult to understand. But do you remember there was a series? There was what was a serial called, you know, what was the serial with the man, the psychologist? He said, "Man, Doctor Nima Afshar hastم."
Yes, exactly. Yes.
Yeah.
Okay.
آپارتمان شماره 13.
Yes.
Yes. Okay. Yes. من دکتر نیما افشار هستم. That is a low tone. Okay. But some people, when they are excited, they actually scream and they say, "Oh, oh." Okay. So that is a high pitch. So we mean the correct pitch or the right pitch. Okay.
It might be important.
It must be appropriate to the situation, really. Yeah. Because when you're giving bad news to people, you need to be speaking in a lower tone and speak more slowly. Anyway, right. Accent doesn't matter really what accent you speak, but as long as it is understood. So they're not looking for any a special accent. Fluency. Well, obviously, fluency means even and smooth speech without much interruption. Good speed and appropriate pauses. Now, there are 2 points here that I would like you to pay attention to. One is appropriate pauses. Okay. Now, this pause, my pause is appropriate because I want you to think about it and to respond to me. And I say appropriate pauses. Okay. Yeah. So I pause. That's a natural and appropriate pause. It means I'm giving you space. So we don't want to speak without any pause, just like a machine. No, we don't want that. This one, no excessive hesitation, repetition, self-correction, or fillers. So what is that?
No, for example, actually, you know that I'm used to, use, and also when we actually tell a sentence, we shouldn't come back and correct it
Good.
too much.
Okay. Yes, correct. No excessive hesitation. Okay. You know, some people are naturally hesitant. I am one of those. I don't speak very fast. I tend to stop and think about what I'm going to say, you know. And this is not. This doesn't mean that I am actually. Um, what should I say? This doesn't mean that I don't know the language. It means that I'm thinking for the right word and naturally. So that's different from when I'm looking for the correct vocabulary to use or the correct grammar. Um, and I will tell you, I will give you more examples. So we say no excessive. Okay. So some people actually naturally and normally hesitate when they speak, even in your mother tongue. So you might be showing some hesitation or speaking more slowly or more thoughtfully. No excessive repetition. Yeah, this is obvious. Self-correction. Yeah, you say something and then correct yourself. Sometimes you do that even if you're a native speaker, and that's fine if you self-correct yourself once or twice, but not excessively. Okay? And fillers. What is that? What is the fillers?
You know,
Good.
actually,
Mm-hmm. Yep.
Mm.
Mm-hmm. No, not sounds. The fillers
That's,
are,
yeah,
yeah,
Words.
word.
Okay.
yes. In my opinion, or as long as I am concerned, or what I think, or sort of, or this, or, okay. So these are fillers. Fillers used to be an invention of teachers to help uh, with the learner's fluency. But nowadays, they accept it as part of the language. They say it is no longer an invention; it is actually part of language. We use it. We do. I said actually, we do say absolutely. Okay. You're absolutely wrong. Okay. So instead of saying you're wrong, you say you're absolutely wrong. Okay. So, but not excessively. Naturally, you can use that. I say, well, I got home late, and when I got there, I was sort of, yeah, knackered. So this is not natural. It means that I'm looking for. I said I was sort of. I'm looking for the exact word to describe myself. I was sort of exhausted. Okay, so that is a natural and not excessive filler. Okay, all right, good. Uh, Appropriate language. Well, we need a professional language, and when we speak to the patient, we need to use lay language. We shouldn't use medical jargon. And um, also, when we talk about positive news or bad news, how we speak appropriately, we need to make adjustments. And in difficult patients who are difficult to convince, or patients who want something in particular, some patients who do not engage, patients who are angry or aggressive, okay? And we will discuss those later. And yeah, the resources of grammar and expression, which is range and accuracy of vocabulary you use, meaning conveyed clearly, question formation, and word choice. The two most important sections of this is this too. Um, so, meaning is the most important part. Okay, so if you use a word which is not understood, you get more negative effect on your score. So the meaning must be conveyed clearly. Okay. And I don't know why the OET people emphasize question formation so much, but they are nearly obsessed with it. They say how you ask questions, which is open questions first and then close questions later. And yeah, I would say they're just a little bit short of obsession on question formation, but that is something they emphasize. Okay, so that is the linguistic criteria, which is 6 marks each. So 6 by 4 is 24 marks. Okay, so okay, speaking. Okay, 3 minutes to prepare and 5 minutes to play the role. It is profession specific, and usually it takes about 20 minutes. Right, criteria. We have linguistic criteria, which is 6 marks each, and 4 of them, that is 24. The communication criteria is 5 and 3 marks each, and it is 15 marks. Okay, so if we say 24 out of 39, okay, so this is nearly 60% and 40%. Okay, so 200 marks belongs to the communication criteria. Okay, right. Okay, so what is this communication criteria? Well, the communication criteria is based on a model of consultation model, which is called Calgary, Cambridge. Okay. I don't know how much familiar you are with this. Calgary, Cambridge model. Okay. And basically, it's there are 5 parts in communication criteria. They say building a relationship with the patient, understanding the patient's perspective, and incorporating it in the consultation, providing a structure, information gathering, and information giving. And this is so important because this is what you can do in a relatively short period of time. And especially because you have practiced medicine before, some of these come naturally and you have actually acquired them. You just need to use them more consciously. Okay. Well, I cut it very short because I don't want to go through the slides with you. I want to see. I want you to see this in practice and to see basically what we do. So there is a stronger focus on communication skills nowadays, and it is there are more clearly defined communication skills requirements. And so what is interesting is the criteria has been explained here. So it actually tells you exactly what you need to do. Okay. So basically, it gives you a scenario of what you need to play. So basically, what all you need to do is actually to memorize all of these and to see you have to do all of these. So these are tasks that you need to do. And there's a checklist more interestingly, which is, okay, there's a checklist here, and this is what the examiners use, okay? So basically, when you listen to the tape, you look at these. So they say, okay, relationship building, that's first, the first of the 5. A1, initiating the interaction appropriately. So greeting, introduction, nature of interview. They say, okay, good, you've done it. And demonstrating an attentive and respectful attitude. Yeah, you've done it. Adopting a non-judgmental approach. Good. Showing empathy for feelings, predicament, emotional state. Good. Okay. So you get 40 marks here. Okay. Okay. So you've and so on. So they carry on, and when they listen, they look at your performance. Okay. So well, let's see what it is. Thank you. So okay.
Do we have that file in our file, the one that you open now? Those information.
Criteria.
I'll send all of them to you, but they're all of them are available in the website, my website. Okay, you can download them from speaking section. Okay, now I ask you, what is a consultation, and then we will discuss those criteria. What happens in a consultation?
A two-way speaking between two person, one of whom might be a patient and another one is a doctor or anything else, nurse or you know,
okay. Well, in our case, it's definitely the doctor. You are the doctor, and that person as the interlocutor would be a patient or a carer of a patient. Okay. Okay. So what happens during a consultation? A patient.
The patient has a concern or something, and we
Good.
need to provide him or her with some information and some general information probably, and what they need to do, like in a specific situation. And it depends on the subject of consultation. Like sometimes it, I think, might be a psychiatrist. Sometimes it might be like parent of a child that they need to do something in a when something happens. I remember those things from our QE2 exam. Like a parent came with a child that had a febrile seizure, so we need to provide them with some information on what to do in a specific situation if this happens, and general information for them that when they need to be worried, when they don't need to be worried, and what they do.
Good. Yes, and that is also based on Calgary Cambridge model, but that is actually it is a more complete in QE2. It's a bigger, more than 5 skills actually. In Calgary Cambridge, you have to cover 14 different categories or criteria. One of them is safety netting, and to make sure that you plan ahead and you say what happens if this happens. For example, you need to cover if the child is breathless, you need to call very quickly, that sort of thing. Okay. This is a simpler one. Okay. Now, we just have 5 criteria here. Well, to make it very simple, what happens in a consultation? The patient comes in, then for a reason, yeah, agree. Doctor asks questions to find the reason. Okay. And then doctor finds the reason. Then what happens? Doctor makes a diagnosis or a decision, and then the doctor responds to the reason. Okay. So what happened? The patient comes in for a reason. Doctor asks some more questions to find this reason. Then when the doctor finds this reason, doctor makes a diagnosis or a decision. Okay. Or maybe more tests, or maybe more questioning. And then after that, the doctor responds to this reason to say yes or no, or different one, or the same one that patient wants, or whatever. Okay. So basically, it's like you go to a shop to buy something, then you get it, and then you come out. Okay. So it's the same way here. Right. And why should we make it so simple? Because we want to structure our consultation based on this. We say our consultation has 3 phases. The first phase is to find the reason. Second one is make a decision. And the third one is to respond to the reason. And that reason, I should change the word reason to agenda. Okay. Do you know the agenda? Are you familiar with the word? No?
Agenda is something like a schedule, not schedule actually, like a
Condition or
condition. Not
Um,
exactly.
Okay, agenda means the reason or a list of things that you need to cover. For example, we say today's meeting agenda includes 5 items. We're going to discuss, for example, um, recruiting more workers. We're going to discuss talking or negotiating with the government for more loans and that sort of thing. So these are the agenda, the list of the things that we have to do. Okay. Now here we say an agenda is basically the reason the patient comes in. Okay. If it confuses you, I can change it to the reason.
No, that's
no,
good.
that's fine.
Okay. So the patient comes in for a reason, and doctor asks questions to find this reason. When the doctor finds this reason, the doctor makes a decision or a diagnosis, and then the doctor responds to this reason. So explains. I'll give you an example. Okay, suppose I'm a man, and I came in and I say, okay, doctor, I've got this chest pain for 2 days, and yeah, I thought I would come and see you because, well, I know it's nothing important, but well, who knows? So, what is the reason I'm here?
Chest pain.
Like probably finding the importance of the chest pain.
Mhm.
Or
Okay, so now if I say,
worriness about the serious problem.
okay, well, what I'm saying is, well, I don't think it's anything important, but who knows? And okay, so is this important for me to come here or not? My language, my tongue is saying that I know it's not important, but then I have booked an appointment. I have come here. I have spent time. I have spent money. Okay, so which one should we believe? So Now, I'll give you another example. The same patient says, "Okay, doctor, I've got this chest pain for a couple of days. I know it's not important. It happens all the time. But, we have a neighbor who had a heart attack just a few months ago. And who knows? So I thought maybe I should come and see you." Okay. So what does that mean? It means that he's worried about a heart attack. And so basically, this means the patient has a concern. Okay. And okay, can you guess what the patient wants?
To be reassured that
Good.
he, don't have a serious problem.
Good. So he needs some reassurance. And what is in his mind? Can you read his mind about
Mm,
chest pain?
Not actually. We need to clarify by asking some questions.
Okay. But I'm saying that, well, I know it's not important, but, well, who knows? Because our neighbor had a heart attack a few months ago, so I thought maybe I should come and see you. So, what is in my head? Do I think what I'm saying? I'm saying I know it's not important, but I think that it is important. Okay? I think chest pain is important, and chest pain is related to heart attack. Okay, so, and you are right. We have to explore this. We have to ask more questions, and that is what we do. Basically, we are like investigators or like detectives. Okay, so that first part. Uh, the agenda is called the ice. Okay. You will see ice, and you may have seen it before. That's the agenda. It means the what the patient thinks, what the patient is worried about, and what the patient expects. So you will see a lot of this ice: ideas, concerns, expectations. Okay. So usually the easiest one to find out is the expectations. Sometimes the patient comes and tells you, "I'm worried about something." Sometimes they come with an idea, but usually you need to find out the idea. But most commonly they come with an expectation. "I want something." Okay. So, in very easy terms, the structure of a consultation is to start, and then um, ask questions, and then make decision, and then respond. Okay, so that is our structure. Start a conversation, ask questions to find the ice. When you find the ice, you decide if it is the right thing, and then respond to it. Okay. Now, okay. For you, because you're experienced doctors, this is not a big deal. This happens all the time. But what is important is to do this more consciously, to stick to the structure. Okay. Because then that is 40 marks basically. Okay. Now, after the structure, we go to the rapport. What is rapport?
Communication with the having a good relationship with the patient.
Good. What do you mean by good relationship?
Like a trusted relationship.
Okay. I'm looking for a better word. Rapport is to establish a rapport, means cooperative relationship and connection with the patient. So basically, the patient trusts you, and then they connect with you, and that would be called rapport. And rapport is one of these criteria that is establishing a relationship with the patient. And that requires a few things that you need to use. And it is, in fact, greeting and introduction. Okay. Then showing empathy. I put it in a different order. Non-judgmental. There was something else. What was that? Greeting and introduction, showing empathy, non-judgmental, and respectful. And say that again.
Reassurance.
Reassurance. I'll keep that open this time. Okay. Right. Yeah. Attentive and respectful attitude. Yeah, I forgot the attentive one. Okay. Attentive and respectful. So, what is attentive?
Showing attention to the patient,
Yep.
maximum attention to the
Okay.
patient.
And how do we do that?
Listen to patient.
Listen carefully to do not interrupt her or him.
Okay.
And
what?
Showing understanding to her, like, I can understand your concern.
Maybe with the body language, like, and with the like word that with the word appropriate word responding to the patient's like concern or what
is understandable, is totally conceivable.
Oh, that is showing empathy. Okay. Right. In real life, when somebody talks to you, you actually nod your head and you say, okay, okay. You maintain your eye contact, you nod your hair. Also, in this examination, yes, you're required to do that, but the examiner actually doesn't see you because they record you.
Yeah.
So you need to show that you're listening, you're showing attentive listening skills. And how do we do that?
You're responding by words, so it should be vocal.
Okay, yes, okay.
Right, okay, good.
Right.
Okay, right, good. Okay, that's what I'm doing now. Okay, right. Yeah, so just some verbal confirmation that you're listening. You can say, right, okay, okay, I see. And sometimes even echoing. You say, yeah, the patient says, well, I've had this chest pain for 2 days. Chest pain, okay, right? 2 days. Okay, so basically you can actually echo the last part of the sentence or part of a sentence which is important or significant. So you can say, all right, okay, chest pain, all right, good, and 2 days, okay, I see. So so that is basically yeah, attentive listening skills, and you get 10 marks for that. Okay.
Yes.
So if you just say right, okay, okay. So showing empathy, you were like the Svandir was mentioning showing empathy. Yeah, once the patient says something which is a pain in it or a discomfort, whether it is in you or in another person or in anybody, you need to say that I share your pain, okay? But we're not saying that I share your pain. It means that I am suffering. No, it means that I understand and I'm sorry that this is happening to you. So, and this is something I have some difficulty with people, because a lot of people say, well, I understand why you're feeling like that. Well, this is understanding. It's just understanding. It's not empathy. So what is empathy?
It must have been very difficult for you.
Good. It must have been very difficult for you. Oh dear, I'm sorry to hear that. It must have been very difficult. Okay, so you need to say I'm sorry, or you need to say, oh dear, oh poor man. Okay, so you need to say something. If you don't say I'm sorry, there is no patty in it. It's just M. Okay.
Yeah.
So empathy means to understand and share the pain. Okay.
Yeah.
Okay. Non-judgmental. Um, um, well, I don't think you're ever judgmental to a patient, but it happens to some people. Um, a patient asks you a question, and you might laugh, and you might say, "Well, that was a very silly question," or "That was absolutely nonsense." But you should never do that in an exam. Basically, you cannot judge a patient, even if they ask you a silly question. We had a candidate who said, well, I went to the exam and I didn't know what to say because it was ridiculous. The patient came in and said, well, I've got a fish bone in my throat for a week. And I just didn't know what to ask him. Okay, so don't judge a patient. So if they say, well, I have this feeling, I have a fish bone in my throat, you need to act very naturally and ask them questions of why they think so. Okay, so non-judgmental. A greeting and introduction. Well, obviously, greeting. Hello, how are you? Introducing yourself. My name is Dr. What's your name, please? Some people say, well, we should say, can I confirm your name and address? Or how may I address you? We don't do that. Why do we make it so complicated? Well, a lot of Indian people say, well, can I confirm your name and address? Okay, we don't want that. Or just simply say, well, my name is Dr. What's your name, please? And then they say their name. And then some people say, nice to meet you, or I'm glad to meet you. No, you're not. It's not nice to see a patient. The patient isn't enjoying your visit, and you're not enjoying your patient's visit. So it's not nice to meet you, okay? So be natural. Just, okay, my name is, what's your name, please? And they say, okay, this is my name. And this is natural, this is professional. And we don't want to say, nice to meet you, or how may I address you?
Like to be addressed, for example.
Yeah, how would you like to be addressed? This is not Anna Karenina, it's just a consultation. So we're not talking to the royal family. So yeah, just natural language. What's your name, please? And how may I help you? Or um, um, uh, well, some people say, okay, what brings you here today? Or what has brought you here today? Things like that. Whatever you're comfortable with, just say it and try to make it easy for yourself, okay? I've been working in an English-speaking country 17 years. I always say, how can I help? And I just don't complicate things. Just easily. Yeah, okay, yes, come in, please. Yeah, how can I help? That's it. So you don't have to be too complicated. Right. So are we okay with rapport and structure? Good. So we will get back to structure later, but now we're saying rapport now. And right, after rapport, it's something I forgot to tell you. If the setting is in a hospital or in a clinic, obviously you haven't seen the patient before. You just introduce yourself first and then ask their name. But if the setting is in a practice which is a suburban practice, okay, and like this, a suburban medical clinic, it means that the patient is registered with you and you're the only doctor there. Okay, so it doesn't make sense for you to introduce yourself and ask the patient's name. You know each other. Okay, so some people ask me, okay, what should we do then? But if the patient's name is not given here, what should we do? What do you think? What options do we have? We we can either ask the examiner. We can ask the examiner, what is the patient's name? Okay, that's one way. Before you start, you can actually, when you're preparing, you say, excuse me, what's the patient's name, please? Okay. Or if you think you know the patient, just say the examiner's name, the interlocutor is sitting there. Because when you go in, they introduce themselves. Say, okay, my name is, for example, Rebecca Peterson. And then you just call her, okay, Mrs. Peterson or Miss Peterson, come in, please. Or how can I help you? So you can do that. Or the third one is you can say any name, anything you like. Hello, Miss Johnson. Hello, Miss Jones. Whatever you like, and it doesn't matter. What is important is that, well, in a suburban clinic, you know the patient, and you shouldn't introduce yourself. You shouldn't ask the name.
So if we do that, do we lose mark?
Mm, Supposedly, you will, because it means that you don't understand the setting. It means that, well, definitely in higher examinations, definitely you will lose marks if you don't know the setting. Here, I would say possibly. I mean, if I were your examiner, if I see you don't know what a suburban clinic is, I would say, well, I wouldn't give you the mark for greeting because it's not relevant. Introduction, if you introduce yourself and ask their patient's name, I'd say this is not necessary to do that. Okay. Maybe I'm too harsh. I don't know. Right. So, okay. So the next one is information gathering, and yeah, and right. So what happens in information gathering? Well, it's obvious from the name. So, but what are the marking criteria? You see, I'm not saying this in the same order. Information gathering is D, is this part, okay? And in information gathering, what you're supposed to do is, yeah, these 5, okay? Facilitating the patient's narrative with active listening techniques and minimizing interruption. We had this before, didn't we? In rapport and attentive listening, okay?
More mark for and yes.
Right, okay.
Repeating patients.
Yeah, right, okay, I see. Exactly. Okay, so that is overlapping with that. Okay, so you see, you get 2 marks for that. It's a,
We get a mark for not saying anything.
Yeah, so it's a bonus point for you actually. So you can actually say, okay. Next one is using initially open questions, appropriately moving to closed questions, and yeah, that is what I'm saying. The OET people are nearly obsessed with, and so they basically look at information gathering. They look at this part most of all, and you see that the next one is not using compound questions or leading questions. Um, you know what it is? Compound and leading questions.
Yeah, when like the asking question that like direct patient with to a certain answer, like or a specific answer, not like it's the opposite of open question.
Okay. Yeah, so compound question is to ask two questions at a time. So the person, the patient doesn't know which one to answer. A leading question is to say something which the patient cannot say no to. And for example, you say, "Oh, does it make sense?" And they say, "Well, of course it makes sense. I'm not stupid." Okay, so we shouldn't say, "Well, does it make sense?" Uh, if the patient says no, it doesn't, then it means that I'm stupid. Okay, or so you know that what you should do. So you know what you've done is wrong. It means that you've judged the patient previously, so you know what you've done is wrong. Okay. Clarifying statements which are vague or need amplification. So it means that when you don't understand something or when you find out something, clarify with the patient. Summarizing information to encourage correction, invite further information. So basically, information gathering, there are two things which are important to know. One is open questions first, then closed, and summarizing. Okay, so these two are so important. Uh, so if I want to say in a nutshell, information gathering is asking open and then close questions. And for the purpose of identifying and exploring patients' eyes. Okay, so purposefully. So you need to gather information with a purpose, and then summarizing information. We will discuss this later because this bit is the major part of the consultation, basically. Um, so, where are we? A structure where the patient comes in, you ask questions, make a decision, respond. Where are we? We're still in part one of the consultation, which is this bit. We are still in stage one, which is understanding the reason the patient is here. And then after that, the next would be making decision diagnosis and responding to the ICE. So basically, this is the first part of the consultation when we initiate, gather information, and then find what the ICE is and then explore it. Okay, so identify and explore ideas, concerns, expectations is the next one. And what is it that we need to consider here? And why is it important? Well, if we look here, understanding and incorporating the patient's perspective. It's indicator B. It means eliciting. What is elicit?
Clarifying or
Yeah, to identify.
identifying, yeah.
And exploring. That's what you said, that you mentioned, that after we find out, we need to ask more questions about that. Eliciting and exploring the patient's ideas, concerns, expectations. And the more we know, the better we can address the problem. So if we know exactly the idea, the concern, the expectation, we can answer to those. Picking up on the patient's cues. What is that?
If patients mention something, we follow that line of we
Yeah.
don't just follow the what we are supposed to. We are having in our head. When the patient directs us to a specific way, we follow that way.
Speaking exactly to the patient's.
So you follow that lead. If they give you
Yeah.
a lead, you follow that lead. And which means that, well, so the cue means that they have something in their mind,
Yeah.
okay? Or they have a concern, or they have an expectation. So basically, it's something the patient doesn't tell you directly, but you can actually pick up and you can understand, okay, because the patient says this, I can say that the patient is thinking about something else, okay? And relating explanations to elicited ideas, concerns, expectations. So later on, when you're explaining, you need to relate your explanations to these ideas, concerns, expectations. In the example I gave you for the man with the chest pain, what is the cue? So,
The patient is concerned about the neighbor's chest pain.
good. The neighbor. I said, well, doctor, I know it's nothing important. It happens to a lot of people, and I know it's nothing serious, but, who knows? Our neighbor had a heart attack a few months ago. Okay. So, therefore, um, this is a cue that there is something in this mind, or there is something this patient is concerned about. Okay. And okay, so if I say, doctor, I've had this cough and cold for a week. I tried all the medicines in the pharmacy, everything which is sold over the counter, but it's not just shifting. So I came to see you to give me a prescription. So what does that mean? What is the cue?
That the patient is not satisfied with the like OTC medication.
So
uh,
once a
they think that it's something important. I don't know.
Seeking other medication.
they wants a prescription. Okay.
Yeah, specific
Okay.
Specific
Okay.
prescription.
Okay. So you can say, okay, what do you mean by prescription? Okay. And they usually, almost always, they say, well, some antibiotics, doctor. Okay.
Yeah.
So, okay. So, yeah, so it says, I've used all the over-the-counter medications. Okay. Everything which is sold in the pharmacy. I've tried everything, but it's not just shifting. So I thought I would come and see you for a prescription. Okay. So basically, uh, okay, another example. Uh, well, doctor, I'm here today. I know it's nothing wrong, but women. My wife keeps telling me you have to go to the doctor, and yeah, so yeah, she's just worried about my weight. Okay, so what is the cue?
The curious patient doesn't want to lose weight.
To lose weight, and he's been obliged actually to.
Right. And does the patient have any eyes, any concerns?
No.
No.
So who has concerns?
His wife, actually.
Okay. So now if I ask the patient, okay, so why are you here today? He says, I don't know. Okay.
Yeah.
So what should we ask then?
We can ask like who, because we need to start about something about the chief complaint. So we can ask when this when is his wife started to be worried about the way his weight.
Good.
Yes,
Yeah.
it might give us a clue about that,
Mhm. Yeah.
like something like snoring at night, or
Mm-hmm. Good.
yeah,
Good. So we explore it basically. So
Mhm.
when you pick up the cue, you say, okay, and
just
so
that, yeah.
and why does she insist you come to see me? And why is that also? And what is she concerned about? What is she worried about? And why did she insist? Okay, so basically, you pick up the cue. So what is a cue? Uh, well, you know how to pick up a cue, but basically, if the patient mentions a third person, it's usually a cue. So a neighbor, my wife, or my friend. I had a friend who had this. Okay.
Yeah.
So a third person, something the patient denies strongly and says, "Well, I know there's nothing wrong with me. I have no problem." Okay. Or the chest pain patient, doctor, I know it's nothing important, but so when the patient is saying, I know it's nothing, but you've come here, so there is a conflict. Okay, so if there is conflicting information, and when there is repetition, well, I used all the medications, all the over the counter, everything that was there in the pharmacy. Okay, repeating
Yeah.
the everything in pharmacy, over the counter,
Yeah.
and prescription. So these are the patterns of the cue. When we find a cue, we have to explore it, and that is the point. Is just picking up is not enough. You need to pick it up and then explore it. Okay? This cue tells you that there is one of these in the patient's mind: ideas, concerns, expectations. And then it requires you to uh, to explore it. Okay? To basically follow the lead, as you said. Okay? So basically, this one is to, um, yeah, explore ice, pick up cues, and respond to ice. Okay. So now, um,
Sorry, one question here. Like in the case of the man who is concerned about the like neighbor's chest pain and heart attack, we want to start like following that cue because we need to like explore patient's chest pain, but
mhm.
how to relate these to the neighbor's like heart attack.
Well, you just say, "Oh, I'm sorry to hear that. I'm sorry for your neighbor." And so, what happened? And it says, "Well, I don't know much, but I just know that he had a heart attack and he had chest pain." Okay, and so how? And are you exactly the same? Uh,
So
yeah.
we go back to patient's chest pain, just so we mention the neighbors like as a
Yeah,
uh,
yeah. If you explore it, then maybe he says, "Well, yes, our neighbor, he was 70 years old, and he used to have diabetes, and so blah blah blah." So, and then you can say, "Okay, so do you think you're the same as your neighbor, or but you are younger? You're like something like 35, 40 years old." And you don't have diabetes, do you? So actually, that would help you in convincing the patient it's probably not a heart problem. Okay. Um, or well, so basically, we say just explore as long as you think it is relevant. But
yeah.
if it doesn't give you a lead, that's fine.
Yeah.
Just leave it there. Okay.
Okay. Yeah.
So this is the first part of our consultation, which is stage one. That's the first third, which is the patient comes in, you connect with the patient, ask questions, identify the uh, ideas, concerns, expectations, and pick up the cues and explore them. Okay? So that is the first part. I think we need to continue with the rest of that next time, which is, I think probably that would be about half an hour, and then we start practicing.
Okay.
Is that all right?
Yes.
Yes.